Hello and welcome to ID Talk, Answers from Infectious Disease Experts. I'm Dr. Nathan Price, a pediatric infectious diseases specialist at Banner University Medical Center, Tucson, and associate professor of pediatrics at the University of Arizona College of Medicine. With Dr. Scott Olson, I am the Arizona AAP Infectious Disease and Immunization Co-Medical Director. This podcast has been created to answer questions from our chapter members about anything and everything infectious disease and immunization related. Thank you for tuning in today. This is the week of August 18th, 2025. So let's get to the questions. First question, are there any recent studies that have shifted your approach to managing common infections? This is a great question. One of the things I've been thinking about lately is sinusitis. As an infectious disease doctor, my experience with sinusitis is a little skewed because I tend to see the worst case scenarios. We often tend to see the ones that have invasive disease that can cause things like osteomyelitis, like Pott's puffy tumor, or invasion into the central nervous system causing a cerebral abscess. A lot of these patients presented with symptoms that were consistent with sinusitis that then progressed to this invasive type of infection. Some of them got antibiotics beforehand, and a lot of them did not. Interestingly, some of these patients haven't had any sinus symptoms at all, but looking at the disease progression, the organism that grew, and the radiographical findings, it's pretty obvious that these infections arose from the sinuses. On the other hand, there are other infections like viral infection and other syndromes like rhinosinusitis due to allergies that mimic bacterial sinusitis. So it can be really difficult to figure out who has bacterial infection and what antibiotics to use to treat and when. In October of last year, there was a nice article published in JAMA about this very subject. It's entitled Antibiotics for Pediatric Acute Bacterial Sinusitis. It's a really nice, short, and concise review about this subject. The authors talk about the definition of bacterial sinusitis, they talk about the microbiology, and they talk about the evidence behind treatment. They mention that the epidemiology supports organisms that arise from the upper airway and the sinuses, things like strep pneumo and moraxella and H. flu, to name a few. They also discuss that things like strep pneumo generally tend to respond to antibiotics like amoxicillin, whereas some of the other organisms produce beta-lactamases that might require a beta-lactamase inhibitor. So generally, people tend to recommend amoxicillin versus amoxicillin clavulanate for the treatment of bacterial sinusitis for this reason, to target those organisms. And there are some studies that show that amoxicillin versus placebo and amoxicillin clavulanate versus placebo have better outcomes when using those antibiotics. And people will argue back and forth about which antibiotic is better. In fact, when I went to a recent meeting at ID Week, which is the meeting sponsored by the Infectious Diseases Society of America, they had a point-counterpoint discussion about which antibiotic is better. And both sides brought up good and interesting and potentially valid points of why someone would prefer amoxicillin versus amoxicillin clavulanate. But the interesting thing to me that they mentioned in those discussions, and they also mention it in this paper, is the high rate of placebo effect in these patients in these studies. The cure with placebo was anywhere from 14 to 80%. And if you look at the trend lines in those studies, the rate with antibiotic was not that much higher compared to placebo. So to me, I felt like in that discussion they were missing a lot of the point, which is most patients with sinusitis type symptoms probably don't need antibiotic treatment at all. And I think a lot of that is because some of these are self-limiting diseases. The other thing is we're probably misdiagnosing a lot of viral illness as bacterial disease, or sometimes allergic illness as bacterial disease. And that's not surprising when you consider what the definition of acute bacterial sinusitis is. On the one hand, it can be persistent symptoms like a daytime cough or nasal discharge for 10 days without improvement. The reason why they discuss that is because usually a virus will run its course of a few days, and so something that lasts a lot longer than that would more likely be a bacteria. But there are plenty of non-bacterial things that can do that. The other definition would be worsening symptoms after initial improvement. And again, the thought there is someone may have had an allergic response, or maybe they had a viral response and now a bacteria came and set up shop, and now you have the real bacterial infection at this point in time. And then the last definition would be severe symptoms, so temperature greater than 39 and purulent nasal discharge for at least 3 consecutive days. So those trials that looked at these antibiotics used those definitions, but again, with such a high placebo response, to me tells me that either we don't need antibiotics for a lot of these, or we're still misdiagnosing things as bacterial illness that isn't really bacterial illness. So what to do? I'll admit I don't know the answer, but it's made me think a lot more about these types of infections. I think a lot of people with the milder symptoms, you probably can do a watchful waiting and look and see what happens and see if things get worse or see if things get better and see if we can avoid antibiotics in the first place. Personally, I tend to suggest amoxicillin first line. And if that doesn't seem to work, then you can think about the broader spectrum antibiotics as needed. As always, look at your patient and see what you think makes the most sense to you and the patient based off the clinical scenario. Okay, next question. Are there any resources or toolkits that you find particularly helpful or that you would recommend to other providers as an ID doctor, i.e. to combat vaccine misinformation? Great question, and I think one that we're all dealing with and we're really going to continue to deal with for a long time at this point in time in this current situation that we're in. The AAP has really stepped up their game. They've now published a vaccine schedule recommendation, which is going to differ from the CDC recommendation because of changes that have happened. They also have a lot of good information in addition to that on their website. They have infographics that can be helpful for patients that you can put up in your office and hand out. And they've got a lot of good additional information for providers to look at. So I recommend that you do a internet search for AAP and immunization, and you'll be able to see a lot of this information that they have available. Another good source for now is the Advisory Committee of Immunization Practices. Now, this is going to probably change in the near future since that committee has had major changes, and we'll have to see what happens. But the good news is that the old documentation that is there available on their website and has been published in the MMWR is really good information. What they do is when a vaccine is approved by the FDA, they then review it and review the science and make recommendations on how to use that, and they publish it in the MMWR. Again, that's currently on their website as well through links that you can click on. These documents are really nice. For a lot of the questions that I can't answer about vaccines that are, first glance in the Red Book, a lot of times these documents have those answers. They go into depth about the science behind the vaccine, the clinical trials that were used, the side effects that happen, and potential problems that can happen. So that's another good source if you're really looking for in-depth detail about these vaccines. And lastly, immunize.org is another group that has good information both for providers and for families, and they have some nice infographics that you can use and share. All right, next question. Can you share your experience balancing the results of PCR panels with clinical judgment, such as when multiplex PCR panels return positive for multiple pathogens? This is another really good question. And there are a lot of different multiplex PCR tests that are out there. I'm going to focus mostly on the nasopharyngeal, oropharyngeal swab type tests that offices tend to have and use. My first answer to this is I try not to use them in the first place for most patients. Now, there are some situations where they have a role, but they're fairly niche. And so for the most part, you don't need all the things that they test for. And quite frankly, when you get the results back, they can be problematic because they may lead you to treat something that's unnecessary or make you worry about something that you don't need to worry about. And a lot of the results that we get, they're really not actionable. The first thing to think about when we're ordering these tests is it going to change what I'm doing? If it is, and it's worth the cost to do it, then by all means get the test. But honestly, if you've got a patient in front of you that has a cough and a runny nose and an otherwise decent exam, are you really going to do anything about the positive human metapneumovirus result or the rhinoenterovirus result, or in an older child, the RSV result? The problem with these tests is that some of them are even broader than that and include things that can be pathogens but are often colonizers as well. So things like strep pneumo, H. flu, Moraxella, and Staph aureus, including MRSA. If this were a test that were sampling a space that's supposed to be sterile, like a joint or pleural space and fluid, and it was positive, then yeah, that test would probably be actionable on the bacterial side of things. But we are sampling places that are non-sterile, the nose and the mouth. And so I generally ignore bacterial results from those types of tests because they very rarely guide diagnosis and management. On the other hand, I've seen lots of patients that have been tested and have been treated for bacterial infections based on those results. And again, I think for the most part, that's generally inappropriate when most of the time it's probably viral illness causing those infections based off of the clinical scenario of what's going on with the patient. Another consideration with these tests is that the cost can be quite high to the patient. Now, some of these are being done in outpatient clinics that they may have more control over that, but if you're in a big institution, the cost is determined by folks, and sometimes that cost is hundreds of dollars and sometimes over $1,000 that goes to the patient after they get this test. But back to the question at hand, what do I do if there are multiple positives? Well, first off, look at the clinical situation. Is there something about it that makes sense? We know that viruses can shed for days, sometimes weeks, and even sometimes for months in certain situations. So do you have a patient that has had off and on illnesses for the last few weeks? Or is there a patient that has had a particularly prolonged illness over the past week or a few weeks? If you've got 2 or 3 viruses that are positive on that test and they've had that off and on, well, it kind of explains that clinical situation. They probably got one thing, then got better, got another, and got better, and then got another. In the setting of the patient that has this illness that seems like it's going on forever, and you've got multiple things, well, again, similar scenario, they probably got one thing, and before they are really getting over that one, the next one set up shop, and before they are getting over that, the next one set up shop. So at the end of the day, when it comes to these tests, look at your patient. Is it going to change something? If it is, and it's worth the cost, then by all means do it. Otherwise, if you're looking for something actionable like influenza, there are other tests that are narrower in their spectrum of detection that you can use. So things that have just influenza or maybe influenza plus RSV or COVID, rather than that whole big test that looks for all of these other things. Okay, last question. Any additional topics or facts that you think podcast listeners would like to know? Well, the usual broken record that I am. Measles is still out there. Syphilis is still out there. Pertussis is still out there, and we really need to be on our toes and vigilant about these diseases because they are going to show up on our doorstep from time to time. One thing about congenital syphilis that I've been thinking about is the RPR and the titer. The RPR, or the other option, the VDRL, measures IgG against inflammation in the body caused by syphilis infection. It's different than other antibodies. Other antibodies, you get the infection, you produce the IgG, it sticks around for years to life. The RPR is different. It goes up while you have acute infection and then goes down after infection has been treated and then eventually goes away over time. When a mom has positive RPR, you worry, does she have an infection? And you have to get more information, obviously, to know, did she get treated recently and now it's coming down, or is this a brand new infection? One of the ways we try to sort out if the baby has an infection is to get the RPR. But again, it's IgG, and it can cross the placenta and be detectable in the baby, but it's really mom's RPR that we're detecting. So what we generally tend to do is see if the baby's RPR is at a higher titer than mom's RPR. And for it to be clinically significant, it needs to be 2 dilutions higher or 4-fold higher in number. And that's because each dilution is a doubling. So for example, if mom's RPR was 1 to 2, and baby's RPR is 1 to 8, even if the baby has a normal exam, we assume that the baby has a higher titer because baby is making his own RPR because of his own infection. And therefore, we call that baby as having congenital infection. But the interesting thing is there are a lot of babies with congenital infection with syphilis who do not have a titer that's 4-fold higher than mom's. And when you combine that with the fact that 60% of babies who have congenital infection are asymptomatic, it starts to make more sense that we're really aggressive with diagnostics and treatment with babies who are born to moms who had syphilis during pregnancy. So keep an eye out for syphilis in these babies that are being born. Remember, the Red Book is your friend. It has a really nice algorithm to follow to help sort out what tests babies need and what treatment is needed. But just remember, just because the titer is not 4-fold higher than mom's titer doesn't mean that that baby doesn't have infection. So follow that algorithm. It'll really help. Well, that about does it for this episode of ID Talk. Thank you for listening. Arizona AAP members can submit questions for future episodes to id@azaap.org. Arizona AAP would like to acknowledge the generous support of the podcast by the Arizona Department of Health Services through the Title V Maternal and Child Health Services Block Grant funding. For more information and resources related to infectious disease and immunizations in Arizona, or to become a member, please visit azaap.org. Thank you for all that you do. We'll see you next time at the next ID Talk podcast.